Thanks, David, for your introduction. Good afternoon, everyone. The previous presenter, Dr. Simon, gave a very interesting touch about anti-biofouling for point-of-care biosensor, which is somewhat linked directly to my talk today, which is about finger prick point-of-care testing of the preeclampsia. In this talk, I'm going to present the voyage of fabrication of the sensor, packaging, testing, and finding the way to commercialization. Before we digging into details of my presentation today, I'd like to give you some background information about the preeclampsia. This is a clinical term of hypertensive disorder or prolonged high blood pressures that develops during the pregnancies. That preeclampsia is happen around 5% of pregnancy around the world. This is well known as a leading cause of infant and maternal death worldwide. And there's a disparities between the maternal death at the urban area in the remote setting and the developing country. Unfortunately, up to 99% of maternal death happen mainly in these regions. For example, in Southeast Asia, Africa, where there are not enough facility for medical intervention, for diagnosis, and also for taking care of the infant. Preeclampsia is also well known. It's a leading cause of preterm birth. And you might imagine already the preterm birth in the infant that will lead to the health consequence in their later stage. For example, the cardiovascular disease, diabetes, and so on. Altogether, the preeclampsia and the health consequence cost over $96 billion in public healthcare expenditure per year. So, despite the seriousness of the condition, the current landscape for diagnosis of preeclampsia at the moment is quite diverse and limited, depending where are you living. For example, the current in the primary care practice is mainly based on measure the blood pressures or colorimetric test of a specific protein excreted in the pregnancy urine. So they give you a color. So that measurement is easy to perform in almost anywhere. However, they have a high level of non-specificity and low sensitivity, because if the pregnancy has some injury or using some medication, they will alter the amount of the protein in the urea, and they will alter the test. The most accurate testing for preeclampsia at the moment, or the gold standard, is the blood biomarker. I can tell you some key players in the field. For example, the Roche ELISIS, the Thermo Fisher Crypta, and the Triage now belong to Allure. So they use venipuncture blood to measure the blood biomarker, absolutely accurate. However, they mainly stay in the centralized setting, which require well-trained technicians, some NACTA lab, and they also require some analytical instrument. These alone are not the answer for pregnancy who live in a disadvantaged setting. For example, in the decentralized setting, in the remote area. Even in Australia, we still have a disparity between the pregnancy who live in the remote area and the pregnancy who live in the urban area. We've been consulted with one of the midwives with years of experience in the region of Australia, like Dr. Priya. She once mentioned that she had to do over 4 hours to bring a blood sample for testing, because the doctor is still waiting to see the blood test result so that he can decide what to do next. And for the case of preeclampsia, somehow it happened fairly quickly, within an hour. So that means that an immediate action needs to be performed. Now, so as I mentioned earlier, the landmark or the most accurate testing of preeclampsia at the moment is based on the blood biomarker. That is thanks to the pair biomarker, namely is SFLT1 and PLGF. Why is matter? Because we have abundance of technology out there that can perform the measurement. However, the measurement will become less useful if your biomarker is not clinical validated. So that means that you can detect it, you can measure that, but the result is, okay, I don't know what to do next. This one is, on the other hand, has been clinical validated in the large scale. And the most important thing is, when you put a ratio between that two biomarkers, they give us an absolute high negative predictive value, up to more than 99.3%. In the other work, they say this two biomarker is good at rule out symptomatic pregnancy. The doctor can, after the testing, the doctor can say, yes, you're safe, you can go home and take a rest instead of like staying another day in the hospital or the clinic. So everything is lined up and then well positioned us to move to the next stage, to develop a sensing technologies that can accurately measure the blood biomarker at the point of care setting. The most important thing I like to stress out here is we can measure from the finger prick blood within a minute and without a specifically training and facility. We spin out a company late December last year to serve as a vehicle to bring that technology into the market. At the core of our sensing technology is the semiconductor sensor or field effect transistor. We fortunate enough being supported by ANFF since 2013. During my PhD, I first started with the fabrication of silicon nanowire biosensing, and gradually I moved into the metal oxide thin film, namely indium oxide, which I'm going to explain the rationale in the next slide. So as you can see right here, it's a typical nanosensor transistor with a source and drain contact which I fabricate at the ANFF. So as I mentioned earlier, the most difficult part to translate a nano field effect transistor into the market is to balance between the sensor performance, the manufacturability, and the cost. The silicon nanowire I mentioned earlier, they are excellent in performance. However, they require electron beam lithography. That means that they somehow limit the manufacturability and also the cost. Imagine you use electron beam lithography to make a disposable sensing cartridge that a pregnancy can use in the remote setting. Somehow it doesn't add up. The indium thin film oxide, in the other hand, they provide an acceptable performance, however, and they also easy to fabricate. As you can see on my fabrication process here, I'm mainly using a sputter coater to deposit a thin film of indium oxide, followed by a two lift-up process, one to define the sensing structure, and the other one is to define the metal contact line, and finally packaged into a workable format. You can see on the right-hand side here is the latest prototype that we have made and developed at ANFF. So after years of testing, we have finally successfully benchmarked our point of care testing sensor against the commercial ELISA immunoassays. We start first with 4 patients of symptomatic preeclamptic patient and 1 healthy pregnancy. As you can see on the right-hand side, we validate against our technologies and the ELISA. We obtain a very high correlated up to more than 98%. The results are very promising. So that leads us to the next step. The commercialization. Since last year, we fortunately been supported by Medical Device Partnership Program, MDPP. MDPP helped us to develop a handheld reader so that we can read our chips. MDPP also helped us to perform the product opportunity assessment. This is very important to ensure that we well positioned in the market scene if our technology is being validated. And the results are so far so good. And as you can see right here, in my hand is the current prototype of the point of care testing cartridge. Yeah. I can give a bit of explanation how it works here. So here the finger prick blood sample, we just simply put on a sample jumper. Add washing buffer on, take the point of care testing cartridge, insert into the handheld reader, walk away. 20 minutes, the result will show automatically on the handheld reader. From there, the clinicians or the doctor will decide what to do next. Hand-free, no hassle with the medical instrument, analytical instrument or facility need. So, what to do next in the next 18 months? From now to the next 18 months, there are 3 things that we need to do. First of all, at the moment, we are actively raising the seed capitals. Within 12 months, we need to enter a design and control phase. For example, we've been engaged with D&I and other companies to define the QMS and preparation of the design document. And ultimately, within 18 months, we need to demonstrate or establish the analytical equivalent against the gold standard, for example, the Roche Elixir, as well as perform the clinical trial and product pipeline. And finally, I'm reaching my final slide. I'd like to acknowledge the ANFF SA, New South Wales North, the hospital, and all of the funding and collaborators. Thank you very much for your listening.
Thank you very, very much for taking us on that journey. It was fascinating, especially some of the unique challenges that we have here in Australia in getting the tyranny of distance and how it actually applies to the work that we actually undertake. I don't know whether to say this is good news or bad news, but you've been let off. No one seems to have got a question to share with us. So please all thank him for his presentation. It was fascinating, and I certainly learned a lot.